Okay.
Cool. So the goal of this training is to go over the basics of documentation. So kind of getting our people in training roles comfortable with documentation to their scope of practice. So we need our documentation to align with department, district, and state protocols, and also have it align with what our biller requires from us. So that's where sometimes you might get QA messages on procedures and things like that. You're like, okay, this might feel a little nitpicky, but it's not. It's to align all those four pieces. So for all documentation, when you log into Siren, it's going to be your EMS number is your username, and the password is whatever you selected. And that's your state EMS number. So then you're going to go in and open an incident. You have multiple ways to do that. You can do plus new, or in the drop downs, you can do Vermont statewide form. We've been having a lot of issues with people's reports, quote unquote, disappearing or like going to no man's land, which then Katie and I or Andrew go back to find them for people. So make sure as soon as you pull up an incident that you put in the dispatch time. It doesn't have to be correct in that moment to the actual dispatch time. It just needs a valid time. So you can click the clock on the side, and then that'll put in the current time that you're logging for, say you're pulling up right now, it's going to be 1940, even if you got dispatched, say 6 minutes ago or something like that. And then make sure that you also then put in for crew member that you at least put in yourself, because unless you have admin access, if you don't add yourself, you're not going to be able to find it once you go back in easily. So those are the first two things that should be done. And then you're going to work your way through your red boxes. So you're adding, dispatch number, type, call, all those pieces. Incident number, which we'll also send out this form so everyone can reference it. Incident number is going to be 25 for this year, SHR, and then 0, and then whatever the remaining numbers are for the call. So you're going to go into that. Oh, just Tom again. And then
Sorry, the split screen was bothering me.
oh, that's okay. Is anyone in? I just want people to be able to see as well, because I can look at my notes if people aren't in the sandbox.
Yeah.
So you'll add a crew member, add yourself. You can just put in a role and license number. Not everyone's defaults to that. Their licensure, that's a setting in Siren, or whatever the role is. So some people have, like, generally they drive, so it's defaults to like primary response driver, transport driver, and then other care provider on scene, or some of our medical attendants. It's other patient caregiver for at scene and transport. So do make sure that you adjust those based on what ends up happening, when you go through your documentation. So whether it's a transport or a evaluation, something like that. So you'll work through your red boxes, and this is all for any documentation. And then, do you want to do turnovers first or 1093s first, Katie?
We can do we can go to turnovers. Or actually, yeah, we can go to turnovers because they're right here.
Okay, so say, this call goes to mutual aid, or we don't have a crew for some reason, something like that. You're going to make sure you put in the time and yourself as a crew member, just so you can access it again if it closes out. And then on the top screen of when you go into your report, you're going to hit this button that says entire call is transferred to mutual aid. So you select that, and then it's going to give you this picture that Katie's on now. Number of patients at scene is your default now. So you'll hit apply changes, and that will then get rid of most of your red boxes. So then you only need your type of call, dispatch, incident location, and then narrative. I recognize that some people use a template. We're going to just talk about mostly the required pieces of information, and then for 1093s and transports, some information that has to be in there, and then people will figure out kind of their assessment and history and how they like to write that to their style, with including all the necessary information. So we're not going to give anyone an exact thing to copy and paste, but these are the components that we're looking for on the QA side and on the billing side, respectively, for these types of calls we're going to go over. So your transfers, super easy. You know, Shelburne was dispatched in town for whatever reason, and that's the reason that's given by dispatch. Unavailable for, you know, this is a second call, something like that, or no crew available, which, knock on wood, hasn't been too much. So any of those calls, and then if you know which mutual aid department took it, you'll also include that. If you don't know, you know, entire call transferred to mutual aid, no contact per SHRS. And then all your narratives need to be signed with at least your last name, license level, and then state EMS number. Some people write like their first initial, last name, or full name. In a nice way, I don't care. But it needs name, license level, and EMS number. So make sure those components are in there for all of your transfers. Thank you. And then this also applies to those times, you know, we get a dispatch number or siren for like when they just need fire, something like that. And so because it generates an incident number, we do have to document it. So then your narrative, the only difference will be that it was a fire response requested only, no response per Shelburne. And then it's the same, you know, really brief information, where they went in the dispatch, and then signed. So that's all you need for those calls. Those are pretty short and easy to do. So that's really helpful, especially when there are a bunch of calls. If you're helping with documentation, you know, this is one that you should be pretty comfortable with pretty quickly. And so that's something that can just take that off the other person's plate who's doing some of the patient transports or other documentation. Any questions on that? Okay. Do
you want to talk about 1093s now, or?
Yeah, I can do that. And then you can do all the transports and procedures and the billing side.
Yeah, that works.
Cool. So I know we talk in training a lot about 1093s, especially high risk refusals. Here is a form we all have seen. So it's your 1093. You have your gray boxes, your vitals. That's really small for my eyeballs. So good idea if you're in a new, especially a newer training role, is to have a copy of this in your pocket. You're also welcome to fill one out on paper if that's helpful to have it in front of you. There are copies in the clipboard. Whatever helps people complete these thoroughly and confidently, I support. So if you're comfortable doing it on the iPad and you're familiar with your gray boxes and what, you know, assessments and things like that need to be done with the situation, you know, the chief complaints that are automatic gray boxes, or vitals that are out of range, or you have a patient that's not completely oriented. If you're comfortable doing that on the iPad, great. Make sure you do know these gray boxes if you're going to do that, or reference it on the protocol app or piece of paper if you're going to go the electronic 1093 route. We've all talked about, you know, high risk situations. The protocol does document very well these situations. The biggest one we see is either those chief complaints of chest pain, shortness of breath, altered mental status, intoxication, head injury. Those or the times that people are declining transport against medical advisement. And those gray boxes all require calls to medical direction. Or you have a minor, which we don't have that happen too much, that there's a minor that we can't get a legal guardian or their parent, someone that's responsible for their care, at least on the phone, and come up with an alternative plan. And then we get those situations where the person's not oriented, but then usually, unless they're a hospice patient or something, a no transfer, and their advanced directive aligns with their goals of not being transported to the hospital. Those are really kind of the situations where we see those altered patients that we are going to leave at home after talking to medical direction. But we don't run into that too much. So the biggest ones that we deal with that need to be documented very thoroughly are those high-risk refusals. So we think they should be transported based on the evidence that we've collected. So vitals, circumstance, patient questioning, things like that. And they do not desire transport to the hospital. So I think we all know and have talked about, 1093s are notoriously the biggest risk factors overall for EMS liability, and calling medical direction helps with that liability. So Dr. George does a training about high-risk refusals, and he kind of puts it that calling medical direction is both, it shows you care. So like say you get subpoenaed for something like this, and you worked really hard to get the patient to go to the hospital, but they continued to decline transport, and then you made the call to medical direction. That phone call is recorded. You've taken all these steps, you've taken the time, you've taken these actions to get the desired goal of getting them transported when they medically require it, but they've pushed against it. So you have that supporting phone call because that line's recorded. You have your documentation, you have your efforts that you've made, and what the patient has signed to, all kind of supporting the decision that ends up, at that point, leaving them at home or wherever they are. So these reports do need to be especially thoroughly done. We'll talk more about transport documentation, but the biggest things for 1093, so your dispatch is going to be the same, your chief complaint is going to be the same, your history is going to be the same, your assessment is going to be the same as you would for any transport. The big changes are your response to treatment and your transport section. So what should be documented in that is all in alignment with what they're assigning to. So all the pieces below this form are all areas that are addressed in that 1093 that they've signed to, whether it's on paper or electronic. So does not desire to transport to the hospital via EMS. And then we say whether, we're in agreement with that or it's against medical advisement. They verbalize logical reasons for desiring no transport and kind of explain out what they've given for reasons, whether we necessarily think it's a great reason. That's for them, kind of up for grabs sometimes, but documenting the reasons that they've given that they do not desire transport, explaining the risks that we've gone over with them. So say they fell and hit their head, we've talked about the risks of a brain bleed, of stroke, whatever risks you've gone over. Disability. Some people are big on the up to death. That isn't actually legally stand up super well, from what Dr. George has talked about in training. But there are certain times where we should make it very clear that, this refusal is against medical advisement. They have a lot of risk factors that make this, in our eyes, a poor medical decision, and go over those risks. But at the end of the day, if they have decisional capacity, they can make their own medical decisions, whether we think it's a great idea or not. But if it's against medical advisement or any of those gray boxes, we're going to then call the doctor. So patient verbalizes an understanding of the risks and clinical situation that you've discussed above, and what the patient's alternative plan is. So whether they're going to self-monitor at home, whether they're going to be in care of their spouse and the spouse is aware, or they're going to call their primary care in the morning or go to urgent care, something like that. Whatever the patient's alternative plan is, you'll document that. And then if it's against medical advisement, who you spoke to for medical direction and any comments they gave in terms of the care, treatment, or alternative plan. So this is here where you would say the patient has decisional capacity. Again, it's against medical advisement, whatever they're refusing transport, that you spoke to doctor, whoever, and they advise that the patient has decisional capacity to refuse that transport, and to follow up if they have any, medical need or whatever they gave you for information on the phone. You should then document that in a clear and concise way in your transport section. Lastly, a few things that EMS completed a Vermont patient non-transport form, whether you did it electronically or on paper. And if you did on paper, please scan it into your report and witnessed by whoever. Ideally, if you're leaving them in care of their spouse and that spouse has decisional capacity and competency, it's a good idea for them to witness and get that person's name. If we're leaving them in like Shelburne Bay staff's care, and they'll check in with the person later, you kind of depend on how, if that's a med tech versus the nurse or something like that, whether you have them witness or you have your crew member witness. And then you're going to say who you left the patient in care of. Fortunately, for those who've been doing this for a little while, they used to be a gray box. If you were leaving them alone, you had to call medical direction, but now you are able to leave the patient alone without that being gray box. So that was a nice protocol change. And then just saying the EMS is canceled and back in service at whatever time. So below are some of your boxes that you would click for different 1093 situations. So here, patient contact made, patient evaluated and refused care, and that's going to be your AMA. And then crew disposition, back in service, back in service care / services refused. And then it gets repetitive, but you're going to say that your patient refused transport. And then your standard ones for refusal is going to be that the patient or guardian indicates ambulance transport is not necessary and release following guidelines. So that's your with agreement or without agreement. And then if it's against medical advisement, you're also going to do the event against medical advisement button as well. So always 2, possibly 3 if it's against medical advisement. And then below is if no care is required. So, someone skinned their knee, Shelburne Bay called or whoever called, we help them up. They don't need any care or transport after evaluation. This one's nice and simple. Just no transport. And then the 2 we talked about. So not necessary, and then release following protocol guidelines. Any questions on that? I know some people have, people have different ways that they write the 1093s, but the points addressed above all should be included in whichever wording you use to fill out your 1093. Does that all make sense to everyone?
Yeah, that makes sense. Also, is there any way you can share this document with us after the meeting is over?
Yes, definitely.
Sweet, thank you.
Sure.
Also, I can now talk about documentation for transports and also what I'm looking for on the billing side of documentation, which kind of is pretty much the same between like a QA perspective. I have, let me scroll back up. So for all documentation, including like 1093s, you're going to want to put in your patient demographics go in here because I just screenshotted it and put it on there. Most of the time this will all, oh, I know why this isn't red. Give me 1 second. Okay. Oh my goodness. Okay. So you're going to want to put in all of your patient information, patient race and gender. If you don't know or you don't want to guess, you can say non-applicable, unable to complete. And then this button right here is where you put in the MRN if you do end up transporting. Patient address section, if you're able to get it, it goes here. Emergency contacts, this is very important for minors, but if you also just happen to have a guardian emergency contact to like a patient we go to frequently, it can be helpful to put it in here because then we can access it in the future. And then medical history section, there's a bunch of stuff in the drop downs for meds, allergies, and history, but if it isn't, you can't find it, you can just type it in this box if it's not a drop down option. Then patient condition, this is where you put your chief complaint. It's important that the chief complaint you enter here is the same chief complaint that you report later in your narrative. For like continuity purposes, that's what the billing agency likes to see. So trying to make sure that you're saying the same thing. If one says like dizzy and the other says dizziness, that's okay. But sometimes I see people write like fall and head pain. And while they are kind of similar, it's preferred if you kind of just choose one or report both. As you can see here, these boxes aren't red because I honestly don't know. But if you can fill out all of these questions about your working diagnosis and everything too, that's great. The patient's primary symptoms, time last known well, what you think is going on, and then your working diagnosis and any differential or other diagnoses that you have can go here. Down here is your signs of suspected alcohol and trauma. This will highlight red if you mark yes in the situation section above this box. You can just fill in cause of injury. There's a bunch of stuff in there. And then there's a few that are just like unspecified, blunt, penetrating, burn, if you can't get in there. But sometimes there's some funky things in cause of injury that you might not think are in there, but are. If it's an MVC, there's a box down here that you can fill in. Main area impacted by the vehicle. If you click on it, it's a picture of a car, and you kind of just choose your best guess. If a car is hurt in a lot of places, I typically just pick one that I feel most inclined to. This is what this. Yeah, what?
Above wasn't red because you hadn't picked your patient contact for one.
Yeah. That I figured that out after when as I was talking, I just decided to just keep going. But yeah, injury trauma here, spinal assessment. Again, if you say there was a possible injury, this will be red. If you say it could cause a spinal injury, this will go highlight red. If you say no, then all the red will disappear here. Next, provider action. To put in your assessments, there's two ways. You can click on this assessment box and go through all of the drop downs. It has everything in either an add or a drop down action. I know some people prefer this version. I personally use the power tool, which is over here to the right. So just click on assessment and it comes up with a bunch of pictures. So you can click on skin and then you can say the skin was dry and warm, the mental status. You can click what you want. It's all the same options. It's just in a different format. And then if you hit OK, they end up being in the same spot. For vitals, we can't download in the Siren Sandbox, but I'm sure it's a pretty easy thing to show. So if you are not sure how to import vitals from the Zoho Cloud, next time you chart, just ask your crew chief. But you click on this button and there's an option here that allows you to do so, and it'll import any vitals that the ZOL took, as well as any EKG or cardiac arrest data. And at least one set of vitals, we like to see qualifiers. So that's basically filling out all of the optional items. So how did you take the blood pressure? Was the pulse regular, weak? Just putting in all these extra things and a GCS score down at the bottom and an AVPU score in at least one set of vitals. You can do all if you want. And if anything changes, you should also mark that as well. But if it's the same throughout the call, one set should at least have some form of more than just as what is downloaded from the ZOL. Then down here on treatment, you can put in your protocols at baseline, general routine patient care, but they also have all the Vermont statewide protocols, so you can search in like sepsis and say that you followed the sepsis protocol. Procedures we will go over in a second. Medications, if you give a medication, click add, click the name, the dose, the unit, the route, and if it helped or not. A lot of the meds we have in Siren are kind of self-populate. I don't think they will in this version, but if you were to say, like, D10, it would auto-populate, like the administration route is IV and the units is grams, and you just have to put in the dose you did. But in this format, it's not linked up to Shelburne, so you would have to do everything if you were just practicing.
Hey, Katie.
Yeah.
If I use the button on the ZOL when I, for example, gave somebody ASA or something,
Yes.
would that come down with my vitals? And
Yes,
would it
that
at least
will
have the
also-
time?
Yes, that will import. It will import red, so it'll import with a timestamp, but you'll still have to go in and
324 and oral.
yeah,
or
the dose, the route,
sublingual.
if there was any
Okay.
improvement, but it will timestamp it. Sometimes be cognizant that if you like put a mark, it'll go into the procedure sections, not the medication section. So you might be like said you do 2 IVs, but really one was an IV and the other one was normal saline. Just depending on what button you press, some people just press the same button, or if someone else is pressing it for you and it's the wrong one. But if there's a random timestamped procedure and a med's not there, that procedure is probably the medication that you wanted to timestamp. Okay, so spinal assessment, vitals, treatment. Now we will go, any questions about just kind of your basic assessment and vitals of all patients?
I've been noticing people, instead of editing the assessment they put in, they just keep adding more assessments. Katie, do you want to show quickly how you can go back in? So instead, each time you click add, it starts a new one. So if you did the,
yeah,
you can explain.
Sorry, yeah. I was just,
Okay.
if you click add with this button and go in and timestamp it and save this assessment, to edit that assessment, you can just click on this box, click OK, and to delete it, you can click X and yes. However, if you make it in the Power Tool, you have to click the X button, open in Power Tool to get back into this format and delete it from here. So you can only delete assessments with the X if they're directly added via the assessment section. If it's a Power Tool, you have to click the X. It's a little scary because you think that, oops, you're going to delete it, but you won't. Open in Power Tool, and then you can delete it from here, or you can add your extra assessments. Is that what you're getting at, Indigo?
Exactly what I was getting at. Thank you.
Cool. Cool. So transports. There is a bit, transports are pretty basic. In the boxes you're clicking, it's going to be, and again, we'll share this all, and it's broken down with what is on here. But you're going to say there was a single patient on scene. If there was a multiple, you can click multiple. That's a bit more complex documentation that we don't need to touch on right now as well. But if there's multiple patients, click multiple, not single. Patient contact made, obviously that's going to be the same for any transport, and patient evaluated and care provided. Sometimes care is refused when we transport a patient, but typically if we're transporting them, we click this first box. The second one would be like if they're agreeable to transport, but like they do not let you touch them or take vitals or bandage their wounds, and they just want to sit there in silence, you could probably get away with clicking that second box. Career disposition is either going to be initiated and continued primary care or assumed primary care. This would be if some first response entity, typically if we were going mutual aid into like Charlotte or Heinsberg was on scene, we would click the assumed primary care button, but typically it's us initiating and continuing primary care and transporting by ourselves. If we transport with a medic, a member of a fire department, or a mutual aid, you want to click transport by this EMS unit with a member of another crew to identify that there was additional services in the back during that transport. And then you also want to choose your appropriate initial and final patient acuity and whether or not a cardiac arrest occurred. So you just say yes or no. And then also possible injury, yes or no. There's also boxes here. If there was any child abuse and neglect or elderly abuse or neglect that you ended up reporting after the fact, you can click that box here just to note that it happened. I guess I didn't put injury. Sorry. Any question about those boxes? Cool. Next to the transport section, transport status and priority is going to come up with this box. You're going to want to choose how the patient was moved to the ambulance. There's a long list, so whether you used a backboard or the stretcher or a combination, you can choose more than one option. And then the position that the patient was secured during transport, most of the time we do semi-Fowlers, but if they're supine Fowlers, lateral, you can choose the appropriate. This is a required thing for pediatrics, but it's also great just to have in every patient. It does not light up red, however. And then transport priority up here. So did you go emergent or non-emergent? We're always going to be transporting via ground ambulance unless our new truck gets wings, but I don't think it's going to. And then transporting traffic alert you can put in if you use your sirens. Hospital team activations down here ends up looking like this. This is if you're a stroke, a trauma, a sepsis, or semi-alert. You can just click the appropriate one, and the time that you put in is going to be, I typically just use the time that I called my phone report at. So if I like go into my phone and Apple says I called at 1824, that's the time I'll put in. Final patient acuity will auto-populate from what you chose in the situation section above, but you can also put it down here. It will change up there if you change your mind. For destination information, we typically just go to UVM, but we are able to add in other destinations such as Porter. For UVM, you can choose any reason. Closest facility is what I see a lot of people do. You can also say protocol, trauma, cardiac stroke center if that's why you're choosing it, but realistically we're going to UVM because that's where we go. So closest facility and protocol are appropriate. If for some reason you do end up transporting to Porter, you might have different options. There's one that says patient or family choice or patient's physician choice, and you would choose that instead because it might not be the closest facility and it might not be the trauma center. Hospital capability and address will auto-populate once you choose the destination name. So if you just start typing in UVMMC or Porter, it'll come up and you can click on it. Any transport, it's super important that we put in mileage. The one that's red is the only one that is needed. It's the loaded trip meter. This could be given from your driver if they record it during transport, or you can also use Google Maps and use the route that your driver took and find the mileage that it gets. You can put on scene and ending if you'd like, but the one we bill off is the loaded trip meter, so it's important that it's in this specific box because we only bill for loaded mileage. We don't bill for the amount it takes us to get to the scene. Then times, which we talked about up top, like with the dispatch and the responding. If you're transporting, these will be red, which is when you left the scene, when you got to the hospital, and when you got in service. Transfer of care time is not in red, but it'll turn an orangey brown if you don't put it in, which is just kind of like a, hey, you forgot to do this, but it's not required to make your form at 100%, but it's great for data collection. So
Katie, you take this out of active every time, or?
So yeah, so these times are all from active or first due. The patient care transferred to hospital receiving agent, that's like when you're giving your nurse report. So that if I like have the iPad on me, I will like click this as I'm speaking to the nurse, or I'll like look at a clock, or I will make it up, or some people just omit it fully. I believe it's fully for data collection purposes. Like I said, it's not a time that's red. The rest of the red times will all be on active or with dispatch. Any questions about those siren boxes? Cool. Transport section for your narrative. It's kind of just what you clicked, but in sentence form. So how did you get the patient to the structure? Every patient moving device transition should be documented. So if you scoot boarded them across the hall and then put them on the stair chair out of the house and then used the Reeves, you want to say you did all of that. If you did do all of that, good for you, but just document everything that you did. What position they were on the structure. What was that?
And that they were secured.
Yeah, and then that they were secured during the movements as well, because that's a liability thing for you. And then what position on the stretcher they were secured, how are they secured? So semi-Fowlers with 5 straps, or the PD mate and all available straps. Did you have an intercept present or any additional personnel? Whether you met a medic en route, there was one on scene. Obviously, if it's a Shelburne rescue, like if Indigo's your crew chief, you don't have to say like medic present during transport. But if you got an intercept to the scene or en route to the hospital, you would want to say like South Burlington Fire Department present for duration of transport, or patient's daughter secured in airway chair for duration of transport, just to note that there was some abnormality of personnel in the back. You can add in your transport priority if you went lights and sirens or no lights and sirens. You want to report if you brought any patient belongings with you, and then that you left them with the patient, so you didn't steal anything of theirs. If there was any changes en route, whether that be improvement, your patient goes completely unresponsive, your patient's symptoms completely resolve, anything notable that happens during transport, you can put in this section. And then where did you bring the patient? What bed? Ward B9. If you brought them to the trauma bay, just put in where you brought them, and then a statement that report was given and care was transferred to a higher level. So a nurse or a doc, whoever was there. Typically, it's going to be a nurse or a nurse and a lot of other people. For signatures, this is a screenshot from our billing policy. But all signatures have to have a reason for signature, a name, a timestamp, and if it was signed or not. A paper copy obtained is also an option. So if for some reason the iPad's not working, the Wi-Fi is not working, and you end up getting a paper copy, you still have to put the boxes in the siren form and say paper copy obtained. I know it's super annoying. If sometimes I'll add them in retroactively if people forget, but not a lot of people use paper signatures, so that's okay. If you are not getting a patient signature, you either need to have the reason documented in the signature box, which I'll show you below, or write in your narrative why the patient did not sign for themselves if it is not readily understood. Like if your patient's completely unresponsive, that makes sense. But if there's some like minor mental status changes or physical impairment, you want to note that in your narratives as to why the patient did not sign for themselves. Any patient and patient representative signatures need the reasons HIPAA, acknowledge release, permission to treat, transport, and release for billing. If it's a patient representative, then you're going to put it in. There's a bunch of different relationships, not just family. Some are legal guardians, some are healthcare personnel, law enforcement are also a patient representative. If the patient is not signing for themselves and a patient representative is not signing for them either, then you need a nurse's signature. At minimum, you need hospital receiving agent and that the patient was medical necessity. They were unable to sign for themselves, and that's why the nurse is signing for them. And then you also are going to want to add an EMS care provider signature, just say crew member signature. So if a patient is not signing for themselves, you should still have 3 signature boxes present. If a patient does sign for themselves, the minimum is 2. You can get more signatures if you want. You can always grab a nurse or family members in addition. But the bare minimum is going to be someone signing for the patient and then you signing as well. Now that we're doing non-transport billing, I haven't gotten a confirmed answer from the billing company yet whether or not the presence of release for billing in this signature section for the non-transports is important, but I've personally started to add it just because I'm not necessarily telling the patient, which is bad of me, even though I'm putting it on what they're signing. But I think that that's something that I'm still trying to figure out on this end. But at minimum, patient refusal of care, patient refusal of transport, and then you can add HIPAA and release for billing, since now we are sharing their information with companies. However, if these are not present, we are still able to try and bill it. So don't worry too much about that at this point in time. Again, for non-transports, you're going to want to put in a crew member signature, and best practice is to have a witness signature. The same way you would if you were filling out the paper form, just to kind of back up that you tried everything you could. The patient either could stay there or really wasn't going to go, and you put in all of your best effort.
Can I add one thing?
Yeah.
Patients that are active, I've seen this a couple times on the QA side of things, which is why I bring this up. Patients that are actively suicidal or have suicidal ideation should not be signing for themselves. That is not a quote unquote right state of mind, and they should not be signing. You should have a nurse sign for those patients.
Yeah. Down here in the signature section is the other reason. So you can say they refused. I've had that happen numerous times. Mental status impaired, unconscious, minor child. They should not sign for themselves. Language barrier, physical impairment. They just were in a car accident and their dominant right hand is shattered to pieces. They're not really going to be able to sign. Transferred care, no access to obtain signature is used a lot when the crew just blatantly forgets to grab a signature, which is okay. If you forget, like it's happened to all of us, just document that you forgot. Never forge a patient or nurse's signature. Not signed. isolation precautions, pandemic, etc. Patients super sick. I think this, I honestly don't know if this was here before COVID times. I'm sure there was other things that we take patient isolation precautions for. But if for some reason you don't want, you know, to hand the iPad to the patient, or the patient is rushed into some isolation room that you can't go back into, then you can choose this option. The billing section, you don't need to worry about, and the service defined questions is empty for us. So those don't necessarily matter. The last thing I will talk about is procedures. So if you have any procedure documented in your narrative, it should be reflected in the Sirens dropdown and vice versa. This ensures continuity and helps with billing. For our policy, the below procedures are required if performed, even if they're successful or unsuccessful. So I'm not going to read this extensive list. Like Indigo said, we're going to share this with you. But as you can see, there is a long list of procedures that should be added. People are getting better about putting procedures in. You can look through this. There is a lot more in Siren 2. You're always welcome to put in a procedure, even if it's not required, if that's something that you like to do. But if it's a required procedure, it should be there. They're all pretty self-explanatory, and I have it broken down between licensure level, so it doesn't get too confusing. If you try for 2 IVs and you only get 1, both IVs should still be documented. 1 successful, 1 unsuccessful. So you guys, I'll let you read this on your own time. There shouldn't be any surprising procedures in here, because we all practice that pretty well. And then at the bottom here, Indigo and I just made like a little general narrative guideline, which I don't know, Indigo, if you want to go over this, I also can.
Go for it.
Sure. So District 3, we use DChart. So the D is dispatch. What were you dispatched to? You can just write what was an active or first due. Chief complaint, like I said above, match what you have in your PCR. What the patient's biggest complaint was. If they're unresponsive, you can say unresponsive. Obviously, they can't necessarily complain of anything. HPI and assessment. Sometimes people can get confused on what goes in what. HBI is the talking, it's the questions. It's what the patient is saying to you. It's the answers to the questions that you're asking them that's helping you narrow down your differentials. So it's why EMS was activated, the history of the present illness, which is what HBI stands for. Any pertinent thing or answer to the questions that you ask. Time last known well. This is where your sample OPQ or STU goes, your pertinent negatives, if there is any recent trauma, illness, sick contacts, and stuff like that. The assessment is then what you are doing to, like, physically assessing them, what you're visually seeing with your eyes. So your mental status, your ABCs, lung sounds, skin, any head to toe assessments or body systems assessments that are done as findings, CSMTs. Additional things like pupils, speech, gait, anything that you're assessing. And then also your BFAST, FAST-TD, 12 lead, blood sugar, capnography, temperature, vitals. This is all going in your assessment section. Treatments are anything that you do to treat the patient, any medications, if they improved or not, and any changes that you or the patient note during your care. Transport section is kind of separated out above top in the document between transport and non-transport, so I didn't re-include it here. And then again, make sure that you sign your narrative with your name, your certification, your Vermont EMS number. At this point in time, if you are a medical attendant, you should be ensuring that the crew chief that you're running with is also co-signing your form. For liability purposes, there should be a ALS provider setting the narrative. If you're an AEMT medical attendant, I am not 100% sure, but you should probably just have the crew chief sign just in case for because you were kind of running it together, co-sign. For complex calls, some people choose to write timelines. This is how I write my cardiac arrests. And Indigo's has a little example down here. Just kind of like a chronological thing for your treatment and transport section. Can be a little bit easier to read when there's a lot going on. So this is another option. Sometimes not just cardiac arrests it can be used for. If there's like a dynamic patient condition changing, seizure patients, I've used this for on I don't know what I just said. Use this too on before. If they're seizing, then they're not, and we're doing like a bunch of different things at a bunch of different times. A timeline can be helpful to kind of just keep track of that all and the response to them at the same time in the same place. Yeah. Any questions?
I know a lot of people are using Callum's or an iteration of Callum's original template. That is fine, but make sure, because his includes like all body systems and everything like that, make sure you're deleting the ones, like if you're not doing heart sounds, which you shouldn't be as an EMT or an AEMT, make sure you delete things like that. Or, you know, if you didn't see a patient walk and we move them, make sure you're deleting things like that, because you know, we don't get lung sounds necessarily on every patient. And so like there are certain templates that are floating around that have lung sounds as clear or skin is pink, warm, and dry and this and that. And so make sure if you are using that template, you're very carefully going through it to make sure you only include the things that you assessed. So please be mindful of that if that's the format you're using.
Yeah. Does anybody have anything specific they want to go over in Siren or documentation? Or questions related to what we just talked about?
I don't think in any of the Siren reports I've ever done, I put the mileage in, so this was good. Thanks. So you must have gone and cleaned that up after the fact, Katie.
Maybe. Yeah. Sorry, I'm watching it transcribe as I speak right now. Yeah, mileage is super important. It is, I know a lot of drivers will like reset it, but it is also perfectly legal just to use Google Maps to get that mileage.
Another good thing to do as you're learning and practicing and, you know, going back and reading people's reports on calls you've been on is really helpful to pick up some things you do like. Maybe you'll see some things like, oh, I don't love that. And so it can help tailor how you write reports as well. And it can be good examples of the things Katie and I talked about, like your procedures and what goes where, and all of that documentation. So I recommend going back and reading reports while you're at the station with some downtime as you work on your own report writing and assessment skills. It's helpful for both sides.
This was really helpful, so we can get the document you went over.
Yeah.
Yes, we'll send it out to the squad, and then since we recorded this training, we're going to put it up on EMS1, or someone's going to help me with that because I'm not good at technology.
Are random people going to be able to watch it?
No, it's just our EMS1, not for everyone.
Okay. Well, seeing as I'm pretty random, I'm going to leave now.
Bye, Tom.
Good night, everyone. Thanks for your time.
Night,
Thank you.
everyone. Thank
Good night. Thank you guys so much. I appreciate
Yeah,
it.
of course.
Also, Indigo, was that a Callum template comment sent at me? Oh, did she leave?
Oh, she did. You're not the only
Thank
person.
you.
How do I stop recording this? Stop recording.
Good night, everyone.